welcome to everybody. Thank you for joining the CRC's Aged Care Impact Series webinar. This is our last open webinar for 2025. Really appreciate your interest and for joining. In today's session, we plan to provide you with an informative and hopefully inspiring demonstration of the art of the possible. My name is Isabel Freen and I will be your host for today's webinar. Before we get underway, I would like, in the spirit of reconciliation, to acknowledge the traditional custodians of the country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. Today I'm joining you from Melbourne or Naarm on Wurundjeri country on the land of the Kulin Nation. So a little bit of housekeeping to get us underway. Today's webinar is being recorded. We will share the link to the recording via email with all those who've registered in the next couple of days. We're going to take Q&A at the end of the session, if that's acceptable to everyone. So please put any questions in the chat. If you think of them as they come up, I encourage you to put them in the chat so you don't forget the question or the comment, and we'll do our best to answer them at the end of the presentation. As I've asked, if you could please keep yourself on mute throughout the presentations, we'd be appreciative of that, but you're more than welcome to unmute yourself when it comes time for questions. The purpose of today's webinar is to provide you with an understanding of Kinnexus, why the Digital Health CRC is investing in building a smart on-fire demonstrator app, the pain points it is addressing, exactly what it is, and to demonstrate live its functionality. We'll then take questions from the chat, and I'll provide an overview of the activities the CRC is involved in by way of next steps. I'm just saying if there's anyone on, John Grimes, I'm going to pick on you. If you wouldn't mind going on mute, that would be much appreciated. The CRC has had the privilege of working with many organisations and individuals over the course of the last 5 years to get us where we are today. Today you will be hearing from these people whose gorgeous photos you can see on this slide. These are individuals who you'll be hearing from who've been absolutely stellar in working with each other and the CRC in helping us to deliver Kinnexus. And the aim of all of that activity is to build something that can demonstrate the value of being able to capture data once at the point of care and reuse this same data to inform delivery of evidence-based care, to support downstream quality assurance and to support reporting purposes. We've called that capability Kinnexus. We're referring to Kinnexus as a policy demonstrator because the CRC and many others, including the Royal Commission in Quality and Safety in Aged Care, want to show the feasibility to government and the sector of implementing a standardised approach to functional assessment of older people. And we want to do that in such a way as to deliver, at the same time, tangible benefits to care recipients, carers, with minimal impact on vendors and providers. So I'm going to hand over to Megan Snewen to talk us through the why and to take the presentation and to introduce our other esteemed colleagues going forward. So over to you, Megan.
Thank you, Isabel. So let's start with the pain points, why we are here. This slide attempts to capture the challenges that registered nurses or other clinicians experience, and it's busy for a reason. For nurses and clinicians at the point of care, there are obvious quality and safety issues that they have to deal with on a daily basis, and these were called out in the Royal Commission. fragmented and incomplete data, lack of national evidence-based functional assessment, limited interoperability between systems and entities, no minimum data set to support software development or sharing of data. These issues are exacerbated by disparate clinical information systems not talking to one another. So everyone is doing assessments in every different which way, apple to apples, pears to pears, pears to pineapples, but not apples to apples. So we've co-developed Kinnexus with nurses and clinical care managers in mind. As the sector grows and diversifies, these pain points will not only get worse without the standardisation of data and workflow, we have to find quicker, faster and more scalable and sustainable solutions to address this workflow and workforce inefficiency with respect to a sector facing constant change. What if Lexi could imagine if the systems were connected, if the process was automated and everyone could use the data at the point of care, embedded at the point of care? What if the clinical care manager or quality coordinator could use the assessment data collated all the way through for a resident in real time, but to support internal continuous quality improvement at her home? And even better, what if Lexi could generate the reporting that she needed to support regulatory and compliance through the National Aged Care Minimum Quality Indicator Program? Even better if Lexi could have that data shared back with her and compare and contrast her QRs with her peers for industry-led benchmarking. So her name is not Lexi, but I have it on very good authority that Dr. Sarah Mayfield at Regis Aged Care has a number of these hats that she's previously held. Would you like to comment, Sarah, on some of these issues?
Thanks, Megan. And it's been an absolute privilege to have been a part of the work that we've done with the Digital Health CRC and with Len Gray and UQ and all the other people involved in ACDC. I think one of the biggest things for us when we went through the process is really being able to understand and unpack the absolute data burden that is on various people, whether it is our front of line staff, our clinical care managers who are responsible for the governance in that home, and then our quality teams that are set up to support the homes in being able to use this information to drive improvement. But the burden of collecting the data is so intense and so much, it reduces the time we can actually then digest the key information that we want to drive improvement and those better health outcomes for the residents and the families who are in our care. So having that streamlined assessment, especially with something like INTERI, which is a validated geriatric assessment form, so that we can elevate and improve the information that we're getting at the very beginning, and improving the way our nurses can work and identify and being able to be top of practice in assessing geriatric care needs. That's one thing. But then collecting that information once and using it for multiple things across not just the individual homes, but for Regis, we've got about 74 care homes. Having the better national insight into what is happening is just such a game changer. A lot of you will have heard me talk before. I'm very passionate about this. I'm very passionate about having a validated assessment tool that we can be using that helps guide clinicians in better decision making, and then having a reduced data burden so that we can actually get the insights earlier, quicker, and drive improvements. I'm going to stop there now. Thank you.
Thank you, Sarah. Really appreciate that. So the background to Kinnexus. Well, to drive meaningful reform, the Digital Health DHCRC is advocating for national policy to mandate standardising functional assessment. And so we thought if we're going out on a limb here, we had better amass the evidence to support our recommendations. So both with the feasibility study by Semantic Consulting and the jointly commissioned CSIRO and Digital Health CRC aged care, the Australian Aged Care Data Landscape Report, both reports highlight the complexity, fragmentation, lack of standardised assessment tools and data requirements across in-home and residential aged care. Both reports point to the need for standardised data and assessment in aged care to allow for that interoperability. One of the recommendations from the Semantic Consulting report, and you'll see the QR screens on the screen, but we've also got these hosted on our website. So one of the recommendations from the Semantic Consulting report was to use the emerging national data standard to build a smart on-fire prototype that could be integrated into any aged care vendor solution, built once and deployed many times. So after 5 years of ACDC and these reports, we committed to this and have built a Smart on Fire app. Kinnexus is an implementation of the INTRI long-term care facility functional assessments for residents in residential aged care facilities. It's deployed into aged care clinical information systems as a Smart on Fire app. It is pre-populated using a FHIR API from aged care clinical information system existing data with the ability to optionally write back, which Ilya will show you today, supporting the process to aggregate, de-identify, review and submit QI data as per the Department's National Aged Care Mandatory Quality Indicator Program and submit through the B2G API portals. It has the ability to drill down based on that aggregated data back to the individual level information, the individual residents information that make up that report. And it supports the interoperability of functional assessment data flowing end to end. So this work has been supported by our wonderful colleagues at UQ and InterA. Len, what does Kinnexus mean for you and your team?
Thank you, Megan. Thank you for the opportunity to say a few words about InterA. InterA systems, if you aren't already aware, are essentially clinical assessment decision support tools designed for aged care, but also there are many tools for other vulnerable cohorts of people like mental health and disability populations and so forth. But the greatest use worldwide is in the area of aged care. So the InterA aged care systems are used in more than 35 countries, and they're mandated by governments effectively in the form of an MDS in at least 8 countries, and that includes the US, Canada, New Zealand and Singapore in our local region. The systems include a set of clinical observations from which the majority of the NQIP quality indicators can be accurately calculated. So the raw data, in order to calculate most of the QIs with very little manipulation, can be calculated from the LTCF assessment. So if it is performed as part of the, as is the case at Regis, every quarter there is a review of the assessment profile and a review of the care plan consequent to that assessment. At the same moment, the QIs can be calculated in real time. So this removes the opportunity, or the need rather, to have a separate data collection exercise beyond the standardised clinical review process that's already entrenched in the organisation. So the Kinnexus model has integrated the InterA system for long-term care so that a model of quarterly assessment and care planning review is able to automatically generate the QIs, giving clinicians and administrators immediate vision of the triggered QIs for every resident, real time. So there's no kind of central processing and sending the data back 2 to 3 months later. It's actually available on the desktop at the time of the care planning review. So this, from a clinician's point of view and from an administrator's point of view, is magic. And of course, Kinnexus then provides the opportunity to share that data with other in-house and external software environments, and hopefully the regulator, in this case, the Australian government. So all of that can happen in one process. and that's exciting. Thank you.
Thank you. Appreciate it, Len. So Beta have been our development partner on this journey, and they've also built an aged care software simulator. So I'm going to pass to Beta to do a demonstration for you all.
Yes, thank you, Megan, and I will continue with a demo part. I will start with some updates regarding the development process. So the biggest change from the last webinar is that we built integration with Likea. So it was a collaboration between Likea and Beta Software. So Likea implemented Smart Launch protocol. So now they can add a button that allow to launch any smart and FHIR application. And from our side, we implemented a simple facade that converts data from Likea Platinum 6 generic API into a U-Core format. So once application is launched, once Kinnexus is launched from Likea, this facade pull all the data in the Platinum 6 format and return back to Kinnexus as a U-Core. Yeah. So I will demonstrate how it works. So I will demonstrate the smart launch process. Once I launch the application, it will be like an empty list of assessment in Kinnexus. I will create a new assessment. I will not put a lot of effort in filling the assessment, but I will do the next thing. I will update Medicare in Kinnexus and demonstrate how we can write data back into Likea. So once assessment is completed in Kinnexus, Medicare is synchronized back, and after that, this data will be pre-populated. So let's proceed with this demo. I hope
Don't
everything.
forget to take. Yeah, you've got control. Beautiful. Thanks, Ilya.
Yeah. Do you see my screen? Do you see Likea interface? That's the confirmation.
Yes.
Okay, good. Yeah. So here you can see resident dashboard in Likea, and here you can see that Medicare number is not filled for this particular patient. In this panel, we have this Kinnexus Smart Launch button that initiate a smart launch. So it start Kinnexus application, and the whole smart launch happen under the hood. So now I have Kinnexus running with context of this resident, Sarah Anthony, as you can see here. And also in the smart launch context, I have information about the current user in Likea. So it is John Smith user, and the same user, the same username is displayed here. Later on, when Jana will demonstrate a page of statistics, you will see an author column where you can see information about a particular user who filled the assessment. Let's proceed with creating a new assessment. For this particular patient, we don't have a lot of information to pre-populate. Basically, just some demographics data like first name, last name, sex, and birth date. You can see that Medicare number is not filled in. Let me copy some valid Medicare number. I input it here in the interface, and now I will just proceed with finalizing the form and set today date as date of assessment. Now the form is completed, and since we have this synchronization of writing data back, now I am updating Likea patient dashboard, and you can see that Medicare number is writing back. So we have this bidirectional way of synchronization. Obviously, once I launch Kinnexus one more time and proceed with creating a new assessment, we have all the pre-populations implemented. So both system is fully synchronized, and they have the same Medicare number in Likea and Kinnexus. Yeah. So I just keep it in progress state.
Ilya, just before you move on, it might be worth getting a comment from the LeadCare guys. Joseph who is online, just to talk about his experience in this project.
So thanks, Megan, and hi everyone. So yeah, we are LeadCare. We are a clinical software vendor in Australia and several other countries out there doing aged care product. We've been working with Binda and DHCRC to automate this process of getting the systems to work together and Kinnexus to be able to retrieve information effortlessly with just a single click. Even if the profile doesn't exist on the other end, it will automatically be created. That's the power of interoperability, APIs, and everything else will be offloaded to Kinnexus to do all the computations or calculations, tabulation of data, and quality indicators. Yep.
Thank you. I won't interrupt anymore, Ilya. We appreciate you, LeadCare. Thanks for being on this journey with us.
Yes, thank you so much for all your hard work in implementing a smart launch. This beautiful demo would not be possible with all your effort. And the second part of my demo is to demonstrate a full-featured workflow on top of simulator. So basically, it will be a repetition of the demo from the previous seminar, but since it's our final milestone, I will do this demonstration one more time to cover the whole workflow. I will start in the simulator, and for a new resident, I will create information about new admission. Once this admission is created, through clinical events module, Kinnexus is notified about new admission happened. And after that, through CDS hooks mechanism, I will see a card in the simulator interface that says that assessment is pending. I will launch Kinnexus, start filling the assessment and pause in filling assessment. And after that, I will get back to simulator and enter more clinical data in the simulator. So it from the real life example, I like demonstrating how assessment could be filled in parallel, like both in Kinnexus and also through the HCare software when for a new admitted patient more data is entering into the system. So once I finish entering data, I will launch Kinnexus one more time and demonstrate how data from two sources merge together. And once the assessment is submitted, the card will disappear in a simulator. After that, I will create a discharge event, and for discharge event, it again will be synchronized with Kinnexus. I will see a slightly different card in the simulator says that that says that discharge assessment should be filled in. I will proceed with filling this assessment, and card will disappear, and also more data will be pre-populated related to the discharge. So let's proceed with this workflow. I created this resident in advance just to save some time, and I'm creating a new admission. Let's choose. It was on Monday. So the system needs some time to synchronize information about admission. Now it is synchronized, so I can see this fancy message that says that 3 days ago resident was admitted, and now I need to proceed with filling the assessment. So I am processing through smart launch mechanism, so I need to enter login and password for the simulator. And now I'm starting filling assessment data. So as you can see, not a lot of data is pre-populated, only the date of admission. And I will proceed with filling cognition section of the assessment, just answering first option for each question. And in the next demo, Jana will show you assessments that filled with more precise data and that make much more sense. Yeah, so you can see that this assessment in the in-progress state. And now I'm getting back into the simulator to add more medical information, simulating this parallel patient information update. I will proceed with creating some allergies to medication. Also, I will create information about immunization. So for inter-array assessment, it is important to check that pneumococcal vaccination was done like less than 5 years ago, and influenza vaccination lasts in less than 1 year ago, maybe. Do it like this. Okay, information about immunization is added. Also, I'm adding some vitals information, like smoking status, weight, and height. Finally, adding a related person as a guardian. Yeah. So we have all this medical information displayed on the dashboard, and let's proceed with continuing filling in the assessment and see how data is repopulated from the simulator. Yeah, so now you can see that previously it was only 3 green sections. Now we have 4 more. So first of all, for health condition, we have information about smoking status loaded. We have information about weight and height. In treatment section, we have information about influenza and pneumococcal vaccination. And finally, we have information about legal guardian. Yeah. So let's proceed with finalizing this assessment. Let's assume it was done the 18th of November. We can see that admission was on 17th. We set as 18th. So now, since we have the assessment completed, this card will disappear. Yeah, so you can see no more card here. And let's add a discharge event. And let's add it for yesterday. Okay. So now once discharge has happened, new clinical event is triggered, and we see this new notification that resident is discharged and discharge assessment should be filled in. Let's proceed with creating this discharge assessment. And for this assessment, you can see that first of all, we have all the information pre-populated. Oh, and I forgot to mention that we also have information about allergies pre-populated here that I entered previously. And also, like this new R section about discharge, it is filled in with date of discharge and where a resident was discharged. So I'm completing this questionnaire for today. Yeah, and yeah, since assessment is completed, this card is disappearing after the update. Yeah, so it is a full-featured workflow that demonstrate the initial data pre-population, data repopulation when we have some updates in the HCare software, CDS hooks that based on clinical events demonstrate notification about required assessment. And now I'm going to pass what to Jana. So she will demonstrate how all this data is collected and composed into statistic suitable for export to B2G API. Jana, please continue.
Yes, thanks, Ilya. Well, let's talk a little bit about the statistics part. And I would like to highlight what we are doing with all these individual assessments that are being collected during the overall journey that Ilya was demonstrating. So can you see my screen? Anyone?
Yeah, all good.
Yeah, all right. So basically, many organizations can be connected at the same time to the Kinnexus platform. Every organization have their own nurse user and care manager user, and while nurses are filling in the assessments, we are collecting all this information in the unified data store in an anonymized way, and we have all this data for analytics, and it's collected and available in the real time. Then the care manager of a single organization can access only their portion of the information, like aggregation of the statistics and ability to submit this information as a report to B2G APIs, meaning that as a care manager of Likia organization, I can see only my own resident statistics, and I will be submitting only this information. So this is just for everyone's understanding how it's all collected and processed. And for sure, I wanted to first demonstrate you the Likia dashboard and statistics. So let's first of all, let's refresh the page. This is how the overview for the care manager looks like. We have the B2G quality indicators reporting page. On this page, there is a breakdown of all the quality indicators that we are collecting. And this in this breakdown, you can see individual indicators, and we can see that this is presented by quarters, and let's say past quarter it was zeros because we have just released this feature, and now we have some statistics, and we can create report out of these statistics, and all these numbers are pre-populated in the report, and you can see that this is pretty good coverage of every section of the report, and the numbers that are missing in the report means that we cannot identify those, because most of these missing items, these are residents that are excluded from the measurement by some reason. For sure, we can do some assumptions, but we wanted to make intentional choices for care managers, so they don't just rely on these pre-calculated numbers that might be going from somewhere else, and just because some residents were excluded, we don't know exactly the numbers, and we are asking them to enter them manually. And it means that 1-2 of those fields will be entered manually in every section, but this is in comparison to all the efforts that needed to collect all the information here, this is very, very little force required here. And 3 sections are not covered at the moment because they're not related to long-term care facility assessment like workforce, consumer experience, and quality of life. Those 3 needs to be provided manually. In our backlog for the Kinnexus project, we put the item to discuss how we can enrich the experience and make it effortless, but it's not at this in this milestone. Well, next, what you can do here, you can go and view individual assessments as a care manager. You're obviously not entering the data into the system because it's not the responsibility of care manager, but care manager would like to dive deeper into the source data and would like to understand what's going on in the department or in the organization, and that's why we provided these raw assessments. As Ilya mentioned, you can see that John Smith user completed the assessment for Sarah Anthony, and we can open this in a read-only mode, and there is a feature called assessment statistics. You can see what quality indicators are triggered by these individual responses for this particular resident. So this is the first step to provide easy tool for care manager to dive into the details of how statistic is calculated and go and check and possibly fix if anything is missing in the system. Yeah, it's right now you just can go to the individual submissions and see this information. And in our backlog, there is a great initiative to provide capability to search, to filter by particular indicators, and to easily navigate through individual responses to identify where these numbers are coming from. So it was related to the LICARE, and now I wanted to show you how these statistics are calculated and changed in real time. To support this workflow, I am switching to another organization. Just a moment. I have it here. Sorry. So this is our test organization connected to the simulator. And you can see that we have a little bit more statistics here. And let's try to calculate some of those indicators. We have recipients with 1 or more pressure injuries, and we are looking at stage 4 pressure injury because we have only 1 resident with this issue. And let's add more data to this particular indicator. To do so, I'm going to simulator. I'm opening some resident from here and going to the assessments. I have 1 assessment in progress, and I will be adjusting information here. I'm going to the skin condition, and for skin condition, I will be adding information about stage 4 injury. So that's it. I will be completing this assessment. Yeah, and now the status, since I have completed the assessment, the status goes from in progress to completed. And now we can go back to our dashboard, update it. Yeah, and now we can see it was just 1, and now it goes to 2 residents. And as I have displayed previously, we have this information. We have this information here about Septimus Weasley, and it was like the assessment was created on 18th of November, and now I have completed it and 20. I can go here to the assessment statistics and find this particular parameters that we have just submitted. Furthermore, let's go to the reports itself. I have one report that I have just provided. Like I have created it from this information, like this, just pre-populated every item, and now we can send it to B2G. Before sending this information, I get the confirmation widget here, and when I'm sending it, the status is changing to submitted. If some validation errors happens or sub-processing errors happens, I will get the status that what happened, and I will investigate and fix the issues with the report. But for now, we have submitted everything, and the data should be available in picture. So that's mostly it from now. I think that's all for my demonstration at the moment.
I've just got one comment, Jana. Thank you very much for that. It's great. I haven't seen the dashboard before, so that's fantastic. Just might like to explain all the work that Beta Software has done using the algorithms from InterA, because that's been a substantial piece of the magic. It's not that you've made up the analytics. It's all evidence-based, based on the significant work that you've received from InterA Australia. Do you want to just comment on your own experience with that work?
Yeah, it was fantastic collaborative work with InterA team. They were like so supportive and specifically, like we worked on a few directions here. First one was to calculate scales and caps that are triggered by the long-term care facility assessment. If such caps are triggered, the nurse user or any other user can see them directly in the on the assessments page. This is first thing that very useful for everyone. I guess InterA explaining it very well, how it's timely indicating these caps are helpful for the residents. And another piece of work was to add some information or align some information in the InterA assessment to fulfill the quality indicators requirements. And this is really great to see how the team is accommodated. We have added few non-InterA elements to this assessment, and then we use the calculations across multiple fields in the assessment to calculate the quality indicators. All the calculations are transparent. We have the documentation around it, so everyone can check and see how the quality indicators are calculated. And yeah, really proud of this result, and thank you very much, InterA team, for supporting this.
Thanks.
Great to see the demo. We've also put these, the workflows that Jana and Ilya showed you in the slide deck as well for your reference. I'm appreciating that it's a bit hard to see. Yeah, and I think we've wrapped up the demos side of things. We do have some time for Q&A. Isabel?
Yeah, well, again, thank you to Ilya, Jana and the Beta Software team for the energy, the skills and the innovation you have brought to this project. Before we go to Q&A, if you can hang on a tick, Annette, what I'd like to do is briefly turn to Tim Blake, who's been our technical advisor for Kinnexus for some reflections on the journey that we've been on since he made or you, Tim, made the recommendations to us back in your feasibility study back in March. So perhaps I could just invite you, Tim, to make some comments, please.
Yeah, thanks, Isabel. I was reflecting on this just before this call, and we started that work about a year ago and reported back in a March timeframe. And essentially that feasibility report, I mean, it looked at the technical feasibility as well as some of the kind of socio-cultural factors associated with the adoption of Inter-RI. But I think really its fundamental tone was a call to data standardisation within aged care, which is something that I think we all want, but didn't really know where to start with that problem. And I think for a long time there had been a standoff with lots of other work going on. I want to acknowledge the great work that's gone on for the November the 1st deadline and all of the work that continues in that space. But I think some people waiting for government to mandate things and government not mandating things. So this was designed as a pragmatic approach to really show the power of standards. I think to show that standards don't have to slow us down. In fact, they can speed things up. And I think the amazing demo that we've just seen has been built in a very short space of time, solving some really practical problems of QI reporting to government in aggregated form. Standards have really greased the wheels of that being possible. Obviously, BEDA have showcased their capabilities too here as well, and we want to thank them for the great work that they've done, as well as Lee Care for being so willing to adopt these new things. But fundamentally, this idea that standards can actually really be an advantage in lots of ways. And several stars had aligned, including the advent of technologies like Smart on Fire that allows us to inject new capabilities into software having been built by third parties, but also the work of the Sparked process. And I want to acknowledge that group as well, who have built some really meaningful standards, many of which have applicability within aged care. So a lot of the clinical work that has been done in that space could absolutely be applied into aged care and massively expedite what I think we all know that we need to achieve. So reflecting on all of this, I think, Isabel, it's been really exciting to see the role that standards can play in doing something like this, where we're helping government by finding new automated ways to report. We're helping aged care vendors by this idea of building something once and deploying it potentially multiple times. And we're helping aged care providers because we can inject new capabilities in record time whilst uplifting the capabilities of both providers and software vendors as well. So I'm really excited. I'm glad that, if you'll pardon the pun, we've kind of lit a fire under the industry, and I hope it can go forward in this same way. And just looking at the call today, there's obviously a huge interest in this topic, and that's really exciting. Thanks, Isabel.
Great, thank you very much. And I promise I didn't pay him to say any of that. We're going to move to questions and answers. We do amazingly have time for questions. If you've got them, please put them in the chat or put your hand up. And I might just ask for some help from my CRC colleagues to identify anyone I can't see. But one of the questions that Ash Smith's asked has already been answered in the chat. Is it possible to report quality indicators areas within an organisation? Currently, do you want to answer that, Megan?
I do. It's not currently in Kinnexus, but we also have that conceptually from what we did under ACDC. So we have a model already, which we will then just apply to the Kinnexus technology. So through the work that we did under research with Regis, with Sarah and Philomena and Intiaz and the team, obviously that was one of their key ways to cut, slice and dice the information as well. So we are aware of that requirement, and we'll bring that into Kinnexus as soon as we have the opportunity.
Thank you very much. And yes, that backlog or the wish lists of all the things that Kinnexus could do is getting longer by the minute. Are there any other questions? If they're not, I'm going to just ask a couple of clarifications from Elia and possibly Jan would like to weigh in here. At the beginning, Megan described what Kinnexus was and talked about the flow from the clinical information system that an aged care provider has. We've mapped that to AU Core, to Inter-A, and then producing the quality indicators. There may be quite a number of people on the call who don't know what AU Core is and why they should worry about it. My simple definition of AU Core is it is the national standard, and other countries have a US core, a Canadian core, etc. But a common way in which to model a concept, usually a clinical or administrative concept, in using the RESTful API criteria, and that any FHIR resource needs to be able to support that AU core model. That's still a lot of gobbledygook to a lot of people. Have you got a simple way, Ilya, of explaining the relevance of the work that we've done here by including AU core?
Yeah, so I think the way how I prefer to describe this process is that AU core is a kind of universal bridge across two systems. So if both system talks AU core, they can easily integrate. And AU core is driven by the community. So if you would like to be interoperable, but if you have some issues in implementation, you can go to the community, ask your questions, or even like contribute to the standard change. So what I think the big amount of work was to first of all see how we can map Inter-A LTCF assessment into AU core, like which specific field of the assessment could be pre-populated from which AU core resources. And once we implemented this work, we tested it it was tested with a simulator, so we see that all the pre-population works correctly. Once we started integration with LeakAir, LeakAir just needed to implement a facade on top of their Platinum 6 API to provide data in AU core format. And once it is done, we just reuse all our previously implemented software to do this pre-population. Yeah, so basically it's how I would like to describe this whole process and how AU core help us fill this interoperability gap.
Excellent. Thank you very much. And no mean feat, but again, as Tim called out, had that not been for the huge amount of work that the Spark program's done to advance AU core, we would not be in the position to align this sort of approach to normalization of assessment data to emerging international standards. So a very technical, but nevertheless a very important point to ensure that what we're delivering here is something that can scale and become useful across the sector. Unless I'm mistaken, I can't see any other questions, and I'm just going to move to the last slide, unless someone holds me up. Just to say that obviously there will be next steps, and from a Digital Health CRC point of view, we will be using Kinnexus as we're describing a policy demonstrator to showcase to industry, to providers and to vendors and to government how the sector could move to a standardised approach to functional assessment without major disruption or cost. I'll come to the hand that's just been raised in a second, if I may. Just to complete this, we are planning targeted demonstrations to both aged care provider groups and peak bodies. And if you would like a demonstration, please reach out to us. We're also looking to significant outreach to vendor groups so that both providers and vendors understand more about the details of Kinnexus, or even why they shouldn't be concerned about the details of Kinnexus, why and how they might be able to leverage this work. But we feel that Kinnexus has already demonstrated, it's been modelled on the Aged Care Data Compare project that produced some great reports about workflow efficiencies and quality of data. we believe from the small amount of testing that we've done so far that this standards-based approach using Kinnexus can significantly address workforce and workflow challenges. Obviously, we're continuing, as we've referenced today, to develop out the functionality of Kinnexus to solve more short-term pain points. And again, we invite you to help us add to that list. But most of all, we're offering to help any provider and their vendor partner to reach out to us to either test Kinnexus in your own development environment or to use the simulator environment the beta have built, so you can see for yourselves what Kinnexus could do for you and your organization. And our offer is that we will provide the technical support to help you launch Kinnexus and our insights to help you explore its functionality. And I'm including Intra Australia, a clinical team who've been very supportive of the beta work as part of this support. This offer is an exclusive offer available until the 13th of February. It's not an open checkbook, but we are really keen to, we're really aware the Aged Care Act implementations have been a huge focus for everybody. We want to extend the opportunity for others to really take the lid off Kinnexus and understand what it might be able to do for you. To help you with this process, beta have produced a user test guide, which is available on request. So our standard email is kinnexus@dhc.com. And finally, we will be also completing the work required to hopefully register the Kinnexus FHIR implementation guide with the Australian FHIR Coordinating Committee. And I should say, because the boss is on the call, and I apologise, Annette, I forgot to come back to you, we are obviously pursuing options for how we scale and potentially commercialise Kinnexus. So that's what the CRC is up to. We're 1 minute over, but I'm going to go to Emmanuel. You've got a question. Do you want to come off mute and ask your question? Or am I talking to a bot? No, I'm not talking to a bot, am I? No. Are you there? No.
And I think just while we wait for Emmanuel, what we can do, Isabel, and what we've done in the past too, is all the questions. I can see there's been a few in the Q&A that have been submitted since we've finished chatting over the Q&As. What we'll do is we'll write up those questions and share them as part of the summary of that goes out from Sam.
Great, thank you very much. Are there any, Annette, did we cover your question? Do you want to say anything?
Yeah, Isabel, I just really wanted to acknowledge the huge amount of work that's been undertaken, particularly by the beta team. We put them on a very tight timeline, and they've really, delivered, and really to bring to life the vision we had when we began this project over 6 years ago. I mean, it's just amazing to sit here today and watch how smoothly what has been a mainly manual task has now, had the magic of digitisation for it. So major milestone reached, but I just really want to reflect on two things, as what Sarah said. It's about improving the way clinical staff work to the top of their practice, and this is allowing them to do that, and that the insights will deliver and drive improvements in the quality of care that we're able to deliver to individuals who are our residents in our nursing homes and residential aged care facilities. So well done, and particularly the Digital Health CRC team. Well done, everybody, and we look forward to continuing the discussion and conversation.
Thank you very much indeed. Thank you to all of you for joining, for your participation and your interest. Please do reach out to us if we've sparked some interest. Where our door's always open, and we need your enthusiasm to move this conversation forward. So thank you very much, and thank you to our presenters. Have a great rest of your day.